Live in 5, 4, 3, 2, 1. We are live now.
Yeah, good evening, everyone. I'm Dr. Paari Selvaraj, President of the Coimbatore Orthopedic Society. Am I audible, Karthik?
Yes, you're audible, sir.
Yes, I welcome all the participants who have joined us in the Zoom meeting for the masterclass webinar on unicompartmental knee replacement. Natural arthroplasty has the time come. On the urges of under the AEGIS of Tamilnadu Orthopedic Association, under the guidance of our president from the Tamilnadu Orthopedic Association and Coimbatore Orthopedic Society, we bring greetings to you and we welcome the speakers, Dr. Ateet Sharma, KD Hospital, Ahmedabad, who's going to give us a talk on indications and technical pearls of unicompartmental knee replacement. Dr. Vetri Kumar, Parvathy Hospital, Chennai, and case presentation by Dr. Bhupendra V. Patel and Billy Paul Wilson from MIOT, Chennai. I welcome the panelists, Dr. Vijay Senthil, GV and Multispeciality Hospital, Trichy, Dr. G. Balasubramanian, Bragathi Hospital, Coimbatore, and Dhanasekaraja, Ganga Hospital, Coimbatore. I ask Karthik Selvaraj to take over the proceedings from now on. Karthik.
Thank you very much, sir. Indeed, Coimbatore Orthopedic Society has been regularly conducting meetings, and we had a meeting last week. Am I clear?
Yes,
clear. Audible.
Yes, you're audible.
So we had a brace course which actually was conducted last Sunday, and we had a very lively discussion on unicompartmental knee arthroplasty. So uni knee is picking up. It's not a new kid in the block anymore because it's been extensively done by many surgeons in India as well. And recently, I had this opportunity to visit I had the opportunity to visit Ahmedabad to see a few unicompartmental knee replacements, and I was pleasantly surprised to see the efficiency and accuracy with which this surgery was being done, and I could see some of the results of this surgery, and which was phenomenal. And but this surgery is not new; it has been in vogue for a long time. But there is still a little bit of an apprehension among the community to accept this operation. So we thought it's an apt topic to discuss and come to a conclusion as to whether our group of patients do we have a group of subset of patients who are fit for this surgery. So we are very happy and we are very grateful to have Dr. Ateet Sharma, a very senior orthopedic surgeon, a robotic arthroplasty surgeon working in KD Hospital, Ahmedabad, who has accepted to talk to us about this. I saw him operate. He did a bilateral and a unilateral with such finish. It looks so simple and easy. So I'm sure he's going to convince us that this is a good operation in select group of patients. And Dr. Vetri from Parvathy Hospital, Chennai, is also going to talk to us about the complications and long-term outcome of uni. After that, we have Dr. Bhupendra Patel, who is a very established, young but very dynamic orthopedic surgeon, arthroplasty surgeon from Palanpur in Ahmedabad. I met Bhupen in one of the meetings, and he's really doing a great job there. So we're very happy to welcome Bhupen and our own Dr. Billy Paul Wilson from MIOT Hospital, Chennai. So they'll present cases, and after that we'll have a discussion and question answer with all the speakers. So I also welcome our panelists, Dr. Balasubramanian. So once we start with the talks and the case presentation, then we'll have questions from the panelists. Dr. Vijay Senthil, Dr. Balasubramanian, Dr. Dhanasekaraja, along with the COS executive, are welcome to ask questions, and we'll have a discussion after that. So Without further ado, we'll ask Dr. Ateet Sharma to start his talk. So kindly share the screen, sir.
Thank you so much, Karthik, for the nice introduction, and I thank the Coimbatore Orthopedic Society for inviting me for a talk on something which is very close to my heart, unicondylar knee replacement. So I'll start it right away. The first part would be indications and contraindications, and the second would be the technical pearls. So why I call this surgery close to my heart? Because, oh, just a minute, why it's not moving? Just a minute. The slideshow is not. Yes, okay. Now it is moving. Why I call this close to my heart? Because this was the first patient which we did 16 years ago. A female, 50 years old, 80 kg weight. And see, this was the partial knee replacement of the UKR which we did. At that time, this was the prosthesis available. Possibly this was the Zook prosthesis from Zimmer. The tibia did not have any keel or any peg, but still the patient is doing good for 16 years now. 2007 we did this surgery. So this is the patient, quite heavyweight, and you can see the incision. The incision is very different from what we put now. So this was our first case before even the advent of or before the Oxford came into the picture. So my second case is an 80-year-old male. I'm showing this because this is the 80-year-old person. This was the knee. The varus stress view shows complete bone-on-bone joint. On table, you can see that the patella is eroded on the medial side. The lateral condyle is still very intact, and still entomedial osteoarthritis with the posterior cartilage intact. The ACL also is intact. So this was the post-op X-ray. This was when we started, after we started doing Oxford. The second case, the youngest of my patients, 38-year-old, and she was suffering from this pain for about 3-4 years when she came to us with these X-rays, and we did a partial both the sides, and this is a 1-year follow-up. I think it has been about 8 years that we have done her surgery, and she is still doing good. And this is the last of my X-rays, and 95 kg lady, 39 BMI, and these were her pre-op X-rays. A valgus stress view, you can see it has fully corrected the lateral, and this was the partial knee which we did on both the sides. And this was the patient, and she was with 39 BMI. So I have shown almost 3 cases of the eldest person, the youngest, as well as with high BMI. So what are the current indications of UK? The first is anteromedial osteoarthritis, AMOA, as we know it. The other is spontaneous osteonecrosis of the knee, SONG. And now, because we have switched over to fixed bearing knees, we can also do a lateral UK. So this is the lateral UK which we can do. Okay, what is AMOA as we write down in our consulting papers? It's pain on standing, severe on walking, and relieved on sitting. In extension, the knee is in varus 5 to 15 degrees. The varus can be corrected when the knee is flexed to 10 degrees, and it spontaneously corrects when the knee is flexed to 90 degrees. So this is the photograph from the Oxford book. See, it is fully corrected when the knee is flexed to 90 degrees. And still the bone and the cartilage is preserved posteriorly. So this is a very important slide because there is erosion of cartilage from distal femur and anteromedial tibia. In extension, there is varus deformity and the MCL is lax. But as soon as the patient flexes the knee, the normal cartilage on the posterior condyle as well as the posterior condyle of both femur and tibia come in contact with each other, and the MCL regains its strength. So we are dealing with a normal length ACL when we are doing a uni, and so it is a purely bony surgery. No ligaments are released in this surgery. The anatomical features, as you can see, the cartilage of tibia is eroded anteriorly and centrally with preserved full thickness cartilage posteriorly. You can see on both the pictures that the cartilage is preserved posteriorly. Both the cruciates are functionally normal. Distal femoral articular cartilage is eroded. Posterior femoral cartilage retains full thickness. Weight-bearing articular cartilage of the lateral condyle is intact, and the MCL is normal in length. ACL also is very important because the unis which failed in the period from 2002 to 2010 was because people were doing it in non-functional ACLs also, and that is why they failed. So Oxford came out with the technique that the ACL should be completely intact or fully intact to do a partial knee replacement or a UK. So what are the stages? First is normal. The second is loss of synovial covering, usually starting distally. Third is longitudinal splits, fibril and fragmented, and absent or rupture. The first three we can do a uni. So this is the first one, absolutely normal ACL. The second one, loss of synovial cartilage on the distal part. And this is longitudinal splits in the ACL. All these three we can go ahead with the uni. In the fourth and the fifth one, the uni has to be avoided and we have to do a TKA. Now, the second important point which comes to our mind is about patellofemoral arthritis. In AMOA, the PFC commonly exhibits chondromalacia, fibrillations, cartilage erosion, exposed bone, mainly on the medial longitudinal facet, the medial facet, and the median ridge. They are much less common on the lateral facet. There are a few papers also. Preoperative genu varum, which tends to overload the medial patellofemoral facet, is corrected by UK, thereby offloading the medial facet. With UK, the kinematics of the knee continue to be normal in the long term, and so the mechanics of PFJ remain normal. So this is the 2015 paper saying medial UK improves patellofemoral congruence. So preoperative PFJ congruence and degenerative changes do not affect UK clinical outcomes. 2017 paper, preoperative patellofemoral chondromalacia is not a contraindication for fixed bearing medial UK. Pre-existing patellofemoral disease does not affect 10-year survivorship in fixed bearing UKs. So patellofemoral arthritis, while doing an UK, the state of PFJ can be ignored unless the lateral side exhibits bone loss, eburnation, or longitudinal grooving, which usually is not there in most of our patients. The second important point is the age. Old age has been proposed as a relative contraindication, but as shown by me, we have done this in an 80-year-old also. In a study based on registry data, it was found that with increasing age, implant survival increased, satisfaction and outcome scores improved, lower morbidity, lower mortality, and this is the final surgery for that patient. We don't need to do a second surgery in these. Second, youth is regarded as a contraindication, which is a myth. We have done it in a 39-year-old and she is still doing well for the last 6-7 years. So medial UK in patients less than 55-year-old, a 2014 paper, estimated survivorship was 96.5% at 10 years. So age need not be a factor for choosing between UK and TKA. If the indications for UK are fulfilled, it can be preferred for all ages. Weight, we are concerned about the weight. If the patient is heavy weight, then you should not do it. We had done in a 39 and even a 40 BMI patient. Obesity is often figured as a contraindication for UK. Studies of retrieved bearing have revealed no association between patient weight and linear wear rate. In 80 super obese patient with BMI greater than 45, there were no failures. High BMI is not a contraindication UK. On the contrary, UK is simpler than TK because the instrumentation works from front. Patella needs just to be subluxed. It does not require to be everted. So does obesity influence early outcome of fixed bearing UK? Preoperative BMI did not influence the early outcome in UK patients. So the classical selection criteria which we have been taught is age greater than 60 degrees, weight less than 82 kg, sedentary occupation, pain localization to one compartment, varus less than 10 degrees, and flexion deformity less than 5 degrees. Supposedly, we go as per this criteria strictly, then UKA can be offered to only 2 to 10% of our patients, which is a very less percentage. Because whenever we are doing a TKA, just have a look at your lateral compartment or the ACL, and you will feel that this patient could have been offered a UKA. So if we use the revised criteria, which is the AMOA and the SONG, then we can offer a UKA to 1 in 3 patients, almost 30%. If you do not go for 30%, at least even if you increase it to 20%, it is worth it, which means more surgeries, more experience, and better results. Lateral joint OA can also be offered to patients with lateral joint arthritis, because mobile bearing is possibly not a good option in these, but a fixed bearing is always a good option, just like this. Spontaneous osteonecrosis of either the medial femoral or tibial condyle presents anatomic features very similar to AMOA. MRI is required to confirm the diagnosis and rule out other lesions. And studies have shown that the results are similar to that of AMOA. So we can offer UK in these patients also. ACL deficiency is a contraindication in relatively young patients with medial compartment arthritis, rupture, and ACL rupture. UK can be done along with ACL reconstruction. It can be a 1-stage or a 2-stage procedure. If pain is the primary complaint, then it is done as a 1-stage procedure. You do the UK, do the trial implants, then do your ACL, and then put the final implants. If instability is the primary complaint, then do ACL first and UK can be done as a 2nd stage. So lateral osteophytes sometimes we see on the X-ray just like this, and we feel that this can be a contraindication, which is not. There is a 2017 paper for this. And this is most important, that bone on bone arthritis is the primary indication for surgery. So this is right. And if bone on bone is not there, go for an MRI, see whether there is something else on this, get the blood reports done, and maybe you will be able to keep this conservative option. So in summary, bone on bone contact is important. Functionally intact ACL, functionally intact MCL, and full thickness cartilage in the opposite compartment. The contraindication include inflammatory arthritis, rheumatoid mainly, severely damaged or absent ACL, bone loss with eburnation and grooving in lateral PFJ, previous valgus osteotomy. So this was the first part of my talk. The second part is the tips and tricks or the technical pearls in UK. The most important is selection of the cases. If we do an error in that, then it is definitely likely to fail. Failure early relates to surgeon technique, and which is why I said that if we can offer it to at least 15 to 20 patients, we have good experience in doing UK. In specialist centers, 93% survival at 15 years. Case selection, intraprosthetic alignment, and implant positioning. These are the 3 common errors. History, where is the pain? Medial focal pain is classical, but still, if the pain is in the whole knee joint, then also a UK can be offered looking at the X-ray. You have to see whether there is difficulty in climbing stairs, variable swelling, startup stiffness, night pain, which can be due to inflammatory arthritis. So varus deformity, is it correctable? Watch for synovitis, patellofemoral grinding test, and fixed flexion. So X-ray is the gold standard, AP and lateral. Well, valgus stress views usually give all the information needed, because if you go for an MR, almost all will show chondral damage, bone scan will all be warm, and arthroscopy will have some degree of chondral roughness. Blood investigations, usually I go for RA factor and CCP antibodies. If they are negative, I can offer a UK to the patient. Lateral disease we do not accept at all, because if lateral disease is there, there are chances of progressive lateral disease, and which will cause the UK to fail. Always undercorrect. In TKA, we always try to balance in mechanical alignment. Now the kinematic alignment slowly is coming into picture, but in UK, it is always undercorrect. better to leave it in varus. So this is a model which shows the condylar load sharing in UKR. So this is the normal alignment. See, it is at number 3. And when we do a 2 degree, even a 2 degree overcorrection, immediately the loading becomes more, and then there are chances that the lateral joint will wear off and our uni will fail. So restore the original biomechanics, return to 3 degree of varus with physiological ligament tension. Second is the malpositioning of the femur. So that is an intraprosthetic malalignment, edge loading, polywear, and early failure, which is due to surgeon's fault. Always try to put the implant close to the midline, because it is if it is away from the midline, the forces would be like this, and there would be early chances of failure. So keep it as close to the IC notch as possible. This is just to show that what is the 7-year survival rate or a 7-year revision rate. In case of Oxford partial knee, it's 8.06, while in case of fixed bearing, it is 5.68. So it's not that mobile bearing is the best. Fixed bearing offers many advantages, and also it has a better survival rate. So this is the incision which I keep. The red line is the incision which you can also keep, but I prefer a midline incision, so that if I have to convert it to a TKR on table, I can do it easily. And maybe for the next surgery, it is an easier incision. So the on table check, the lateral condyle should be intact, the ACL should be intact, and the patella should be good. We have to remove the medial and the lateral osteophytes. And this is the tibial cut, the tibial biscuit. And it is easier to remove the whole of this tibial biscuit in extension. It is easy. Anvil osteophyte have to be removed to prevent the Marie-Antoinette effect. Otherwise, the ACL will tear in the long run. Linea terminalis should never be violated, both on the lateral and the medial side. The tibial plateau fractures can be devastating. So in a TKA, the femur cuts are more important because notching and everything is there. In case of UK, it's the tibia which is more important. Anything wrong in the tibia and your UKA will fail. Do not raise your hand during vertical resection to avoid cutting posterior cortex 2 down. Secure the tibial resection guide with 1 pin only, because 2 pins can lead to stress fractures. The goal is 7 degree slope. Do not release the MCL and do not place the bearing too tight. So this is the stress levels which are shown in the tibia. Normally, the gray part which is showing the stress here. If our horizontal cut is more, there is slightly increase in the stress on the upper tibia. But if the distal cut is, if the vertical cut is more, the stress levels are very high and there are chances of a tibial fracture. This should be avoided at all costs, because otherwise there would be a tibial plateau fracture and the UKA will fail. Cementing technique is crucial, and equally important is the cement removal. So these are all the technical tips which I thought I should give. And thank you so much for the patient listening.
Excellent talk, sir. Thank you very much.
Thank you.
I think you were a little, since I told you 15 minutes, you actually rushed through, I think, but there were a lot of points.
Okay.
Points. I think there will be a lot of questions also. So
Sure.
we'll quickly finish the next talk and then we'll go ahead with the cases. I invite Dr. Vetri from Chennai to share his slides.
Hello, good evening, everyone. I hope I'm visible, and just trying to share my screen. I think it's going to work now.
Sir, you
Says,
can...
you cannot start sharing the screen while the other participant is sharing.
Okay,
Sir,
I'll stop.
Yeah, I can stop.
Yeah, I did. Yeah.
Sorry, extremely sorry about this technical glitch. It's asking for some permission and it is asking me to quit and reopen. Is it okay?
Please,
Yeah. Can
please
it do
that.
it?
Yeah.
Really quick one. Yeah.
You want us to proceed with the next case or?
Probably just 2 minutes. I can do this.
Give it a try.
Yeah, sure. Thanks.
Are there any questions?
Karthi,
Hello.
can you hear me?
Yes, sir. Yes, sir. Go ahead, sir.
Can I ask Dr. Ateet a
Yes,
question?
sir.
Yes, please tell me.
Dr. Ateet, I'm Dr. Balasubramanian.
Yes.
How many uni you have revised to total?
Sir, I would say that out of 10, no, not out of 10, percentage wise, if you see, it's about 5%.
Okay.
Yes.
So what I'm asking, when you revise, is it as easy as virgin knee or is it little difficult?
Sorry. You are
when you revise to total knee,
yes.
Is it as easy as a virgin knee or is it difficult or you have to put any wedge or anything like that?
Okay. I'll just point my mistake that I was thinking that you have asked how many you have to convert from a UK to the TK on table.
Okay.
How many I have revised from UK to TK have been 3 till now. 3 till now. And the revision is easy because the tibial cut is only 4 millimeters, the medial tibial cut. So if you cut the lateral tibia to the same level, you are able to manage in 13 or 15 poly. So you don't have to put a wedge or a rod, and you are able to manage with a 13 or a 15 poly.
Okay, even 15 is too big, you know.
Yes, it is. But assuming that you are revising it for some reason, then yes. So instead of putting a wedge and a rod, it's better to put a 15 poly.
Okay.
Yes.
So in other words, you had to go for higher constraints when you had to revise the uni, right?
Yes.
I think Dr. Vetri is ready. So we'll go with Vetri's talk and then we'll continue the questions. I'm sure there are a lot of burning questions. Yeah. Vetri, go ahead.
Yeah. I hope my screen is now.
Yes, you are perfectly visible.
Perfect. All right. Thank you so much for giving me this invitation. I thank the Coimbatore Orthopedic Society for this invite. However, this is not really a simple talk for me. Talking about complications and long-term outcomes of uni. I will be, as a surgeon, we are always really happy to share our good X-rays. So when I was preparing for all this slide was almost like a confession corner for me. Just looking at back, what kind of complications I've done during my learning curve of uni. All right. So these are my disclosures. Well, when we talk about complications and when we look at any registries, these are the common reasons which is being quoted for the complications, and we are going to look at each and every one of them. And I will also try to share. I'll also try to share how well I can, give the best practices to avoid such complications and how to master the technique of unicollar knee replacement surgery. So initially, when we start performing uni surgeries, we start looking at these kind of X-rays as a very enthusiastic young surgeon, trying to do unis. We look at these X-rays and we find it's a perfect candidate to perform a unicollar knee replacement surgery. The lateral view shows perfect ACL is intact. There's no anterior translation of the tibia. Proper grade 4 osteoarthritis on both the right and the left and the in the medial compartment. So it's pretty good to go for a unicollar knee replacement. But then when we look at the HK axis, the patient didn't have a proper good varus deformity. It's almost like a neutrally aligned knee already. A very few subset of patients, they do present something like this. It's a proper medial compartment osteoarthritis, but then this patient has a MPTA of almost 90 to 91 degrees. So it's extremely important that we don't under-resect the tibial component or the femoral component, because if you do so, what happens is you create something like this. So I've created a patient from a neutral axis to a valgus knee. So that's what I've done. But then at the end of the day, I mean, it's now almost 3 years following the surgery. The patient is not complaining any much. She's pretty happy with the pain relief is there, but then still she's walking with a valgus knee. And I'm sure it's going to go with a lateral compartment progression in any time soon. And probably I might have to convince her for a lateral uni at that point of time or convert to a total knee. And we'll see how it goes later. So this is now almost 3 years now following the uni compartment, and this is the current scenario. So what I learned from this is, as the previous speaker said, it's very important that we don't, overstuff the medial compartment. It's very important to undercorrect it. It's actually much better to, if a patient comes with a good varus knee, those are the patients whom I'll really pick, so that I can easily correct it and I can put it almost undercorrected or just neutral is what we are trying to aim. And unis especially, they do extremely well when we do a surgery for a proper intra-articular varus. So if it's more towards a constitutional tibia vara, where there's a tibial bony varus, then I would more lean towards an osteotomy patient, towards performing an osteotomy. But however, if it's more of a proper intra-articular varus, then they are the best patients for me to perform an unicondylar knee replacement surgery. So the most important point here is we try to undercorrect. There is, in fact, these patients, they do much better when putting them in the neutral. So HK axis, what we aim is a little bit of undercorrection, somewhere like 3 degrees is what I normally aim at. And then the tibial periprosthetic fracture, this happened during my very initial phases, probably in the first 10 cases of my uni replacement. We almost implanted, you can see that's a C-arm shot, which has been there on the left-hand side. We almost implanted the uni thing, and then we did the poly, and then I was like malleting it. And then there is the poly was like, was not, it didn't go well. There was a bit of laxity, had to go for more and more poly to, compensate it. And then somewhere it didn't feel right. So when we took an C-arm image, thankfully we diagnosed it right that time itself. And there was a big, medial plateau fracture. And then what we did was, on table itself, we just converted into a total knee replacement, and it was much easier actually. We just managed with the stem and poly. Also, you can see that we didn't have to go for a very thicker poly, but thankfully we managed it well with a tibial stem. So now it's almost 5 years following this fracture, and patient is doing pretty well with this total knee replacement. So points to learn here is, just like the previous speakers spoke. The sagittal cut plays a very important role, and where we are going to place the sagittal cut is just in the upslope of the medial tibial spine. So in fact, when we operate on a very short, stout female, it's more better to err on the towards the lateral, more towards the medial tibial spine. It's even okay to take few fibers of the ACL, only when the patient is pretty short and stout. And the aim of the sagittal saw is more towards the femoral head of the femur, so that the orientation, the rotation of the tibial prosthesis is pretty good. And then it's very important that when you do a posterior resection, you don't, take your hands up like this. So it has to be on the tibial plateau. You just have to, take a nice cut over that. So that's really important. And also limit the number of, unlike a total knee replacement, try to put maximum as 2 pins. 1 pin is mandatory, but then maximum you can go as 2 pins. That's what you do it in order to prevent these kind of fracture. So now we are moving, also shifting more towards a kinematically aligning these processes. So that in that way, we try to fracture. And so here what you look at is kinematically, when you kinematically align these processes, the keel cortex distance increases. The keel is all facing more towards the weight bearing axis. So there is a much better load sharing, and there is a less stress which goes on the tibial plateau. And yeah, so as also it's very important to have a right tibial resection depth. The more you go down, the surface area of the resection also, the surface area comes down, and the keel cortex distance becomes very, very narrow. And that's exactly the perfect storm. That's exactly the perfect storm for you to perform to happen a tibial plateau fracture. So again, people who are converting more towards kinematically aligned total knees might know this paper, very popular one. Only 1.1% of the patients are actually, having an MPTA of almost 90 degrees. Most of them, the mean average MPTA is somewhere like 87, and the mean LDFA is also somewhere like 87. So it actually makes more sense to perform a uni in a more kinematically aligned way than performing it in a perpendicular cut. So there is also a recent paper which shows that when you do a alignment tibial cut more in the varus, the keel cortex distance increases, and thereby there is a incidence of fracture is much lesser. Whereas when you put it more in the valgus, that's like trying to put the tibial plate more perpendicular, your keel cortex distance actually comes down. And very similar to the resection level as well. The more you resect, the more the depth you go down, there's a higher possibility of getting into a fracture. So how we do this kind of, varus, it's people always comment, it's very easy to say it's, to have 3 degrees of varus, but how are we going to do it? See, again, when we perform a kinematically aligned total knee replacement, so that's how we normally plan it. We try to plan to, see how much exactly is the varus I'm trying to keep it, and how much is the shift of the ankle clamp is what, how much shift laterally I have to do it is what I try to calculate over the pre-op planning itself. And if you can see, most of the time my ankle clamp will be mostly towards the lateral or slightly just beyond the lateral, just before the lateral most endpoint. So by that, we try to get almost 3 to 5 degrees of varus in the tibial resection. And finally, while implanting, while preparing the tibia, again, it's very important to be really meticulous and gentle, especially when we do on patients who is very stout and short females, obese lady with osteoporotic bone with less bone stock. The posterior blowout is very commonly, it tends to happen when we prepare the tibia keel, and we need to be extremely gentle while doing it, while preparing the tibial keel. And the most commonest reason why a uni gets revised is actually an aseptic loosening. And I would say it's like the third most common reasons. So here for people who commonly perform total knee replacement, the image on the top is actually a normal lucency. So that's a very common thing which you see following a unicorn knee replacement. A nice homogeneous radiolucent line is pretty normal. That's primarily because of the stress shielding, and these lines will normally might stay, or it might get better probably in a year or two. Whereas the image in the down is actually is loosening, where you can see a non-homogeneous kind of osteolytic zones. So that is exactly when you think it can be a loosening. So the common reasons for aseptic loosening are primarily it's because of a malalignment. When you normally undercorrect it, especially when we perform on a very gross constitutional tibia vara patients, you undercorrect it and you leave the deformity. So probably the chance of having a higher loading of the medial compartment can happen, and invariably it can lead to a aseptic loosening. And also when we perform unis, especially the fixed bearing, it's also recommended for fixed bearing to do that, to go ahead and perform in an ACL deficient knees if you can reduce the tibial slope. But probably again, that's when we also looking at probably these knees can fail much earlier because of aseptic loosening. And when we resect too much deeper in the tibial side, and then we shift the joint line more distally, we are going to create an asymmetric joint line, and that's again we load the medial compartment much more, and then there is a higher possibility of aseptic loosening. And when you prepare the femoral, you need to be extremely meticulous and during the preparation of the femoral peg holes. A case example, so this is a very young lady, 42-year-old female, has bilateral grade 4 osteoarthritis, both medial compartment is involved, and but ideally speaking, this lady, you can see it's a very gross varus, and the gross tibia vara is there. And actually when you look at the joint angles, both MPTA is off, LDFA is off. I would love to do an osteotomy for this patient if the patient is a male patient and their expectation is pretty much on an active lifestyle. But then this is a stout lady, again, just a basic homemaker, If I had to do an osteotomy, HTO will definitely screw up. We will keep the MPTA to beyond 95 degrees, and that will also spoil my future directions of total knee. So the best option for me is to either do a double level osteotomy, but I feel when I have to address both the knees for this lady, probably a double level is not going to be a very conducive situation for her. So I had to go and do a bilateral unicondylar knee replacement. So, well, I put this X-ray. I mean, this patient is not having any aseptic loosening. It's again more than 3 years now. She's pretty happy with her knees. But then I put it. It's a very conscious decision which has been taken. So I've still put the alignment is still in very much in varus. But then I know it might not be like surviving for like 15 to 20 years. If it survives, it's very good. But then if it's not also, even if it survives for 10 years, I'll be happy that I can convert at least easily from here to a total knee. So it's a very conscious decision which has taken, despite knowing that this might fail early. So as I told you, this first image on the left shows an asymmetric joint line where the medial compartment is they have distalized the medial joint line where compared to a lateral joint line. So that's one thing. But again, the patient is doing pretty well at this point of time. Might be a 3-year-old X-ray. So other ways to avoid a femoral component loosening is to put a lot of drill holes, but mind you, put the drill holes only in the femoral component, not on the tibial side, for the same reason, not to weaken the tibial plateau, and be meticulous while preparing the cementation in the femoral component. So polywear is a very common catastrophic thing which used to be there happening in the past. So this is one major reason why total knee started to take over. It's a common reason to fail early in the 1970s and 1960s, exactly when total knees were like doing extremely good. And that's primarily because of poor sterilization technique, and unis as such has been performed very less, and their shelf age used to be for more than 1 year, and the polys gets oxidized. And when they use a very older poly, that to a gamma sterilized polys and very thinner poly materials, it leads to a very catastrophic. And almost, this is a study which came up with an Anderson Orthopedic Research Institute, and they found almost 80% of their unis failed within a year. So that will lead to them to investigate what was the actual reason, and then from then onwards, the companies have changed their polys, and now we all get like a good highly cross-linked poly. And then FDA standardized the poly thickness that as minimum should be a 6 millimeter thickness, and a better sterilization technique has improved the poly wear. So, but from a surgical technical point of view, so what we are looking at is a good tracking. So both in flexion and extension, we don't need any edge loading. The femoral component has to track well right in the center onto the tibia, right throughout the knee range of motion. And the femoral component positioning is very, very important. It has to be aligned to the tibia so that there is no point loading also. So how I normally do it is like once we do a tibial cut, we are sure that I've dissected the tibia just like the way I planned it. And then when we position the femoral component, you position it, put a small a pin on top, and then you use a spacer block so that the femoral component gets aligned automatically as per the tibial resection. So also recently, I went through a demonstration from a company called Consensus, where they introduced this Tahoe system. There also, I found a very nice instrumentation where which nicely aligns the femoral component onto the tibia, especially while preparing the femoral component. So that's a pretty good kind of instrumentation to use when we perform a fixed bearing unicondylar knee replacement. Well, this is not my case, but then this is something which has been reported, an injury to deep MCL. Again, whenever we encounter this, it's really hard to actually identify on table because normally you might try one size of the poly, but then it might not be the same size which you'll have to end up when you put the actual implant. You'll have to overload because the MCL of laxity, you keep overloading it and you might end up in a valgus knee. So a few tricks which we often we do to avoid injury to the deep MCL is there is no releases unlike a mechanically aligned total knee replacement technique. There is no release here. Just a tad bit, we expose it on the anteromedial aspect of the tibia, and then we nicely, the moment you see this, you can slide this, curly whirly retractor. Again, this is a retractor which has been designed from the Oxford group, which nicely helps to, slides between the tibial plateau, the rim of the tibial plateau, and that's the one which protects the MCL. And so that's very important, instrument in order to avoid an MCL injury, and will not chase the osteophytes to remove it. And also, when you do a tibial cut in more in the varus, normally you will be resecting a good amount of bone in the medial side of the resection as well. So that's the way we remove the tibial osteophyte also, and also always leave a rim of medial meniscus whenever you perform this procedure. So bearing dislocation is again, which I have not encountered so far, but it's again reported. But then the incidence is pretty rare. It's commonly, happens, when you are in the beginning phase of your career, because of the mobile bearing, we are always tend to, we have a intensity to overstuff it. But the most commonest reasons for bearing dislocation is distraction, when the right balancing in a mobile bearing is extremely important. And, the other commonest reason is your sagittal cut of the tibial component is not right. If your sagittal cut is more internal rotated, or if you have turned it more towards the ASIS, when the femur tracks the poly, when the poly goes, travels to the more posterior aspect, and that's the time it can hit the lateral wall of the tibial component and it can spin off. But however, if at all you get any bearing dislocation, you need to understand what is the reason behind that. If it is because of an impingement, probably we need to remove the reason. We need to remove the cement, and we can try it again. Or we can add a thicker poly if it's because of a distraction. Or if it's a recurrent poly bearing dislocation, probably we have to think of converting into a total knee or converting into a fixed bearing device. And this is again one of the most common reason why unis gets converted into total knee when you look at the registries. And that's primarily because of the unexplained pain. And this kind of patients do present to us, especially they also typically tell us that I get the same pain when I used to, why I came to you earlier. So that very kind of similar pain is still persisting is what they might tell you, but that's primarily because of the tibial strain which happens because of the implant loading. And these things will normally settle down on its own for maybe it can take a year or even 2 years. All we need to do is just reassuring them that it will get better. But still we have to wait for the results about I believe that when you kinematically align the tibial processes, I think that will also get better. The tibial stress should get better. So I think this should also get better now. And the other reasons for unexplained pain is going to be whenever we have a much more bigger component in the tibial component, there is a high possibility, if it's more than 3 millimeters, there's a high possibility that it can irritate or impinge the MCL. And whenever we do a fixed bearing uni replacement, so patellar impingement is also something which we need to look at. We should always try to undersize the femoral, not to oversize the femoral component. So that's also pretty important. And as Dr. Sharma mentioned, do not perform this procedure for a grade 3 ONE. Just merely looking at the joint space narrowing, if we need a proper grade 4 osteoarthritis, because most of the time it can be because of a different reason. Probably a mucoid ACL might be creating so much of pain, and if we perform a uni for such patients, then these patients might still complain of pain. Also, do not how to deal with it, not to revise unless we identify the. Hello.
Yes, go ahead, Vetri.
Yeah, sure. Okay, sorry. Yeah, so not to revise until unless we identify the problem. And always try to reassure these patients and see if it gets improved with some physiotherapy. And most of the time, these patients will get better by a year or two. And a few instruments which I make sure that I have during my uni surgeries are having an arthroscopic probe to remove the posterior aspect of the cement from the posterior aspect of the tibial component. Use a metal suction tip so that we can nicely dry out the peg holes when you do a femoral during the positioning, the cementing the femoral component. An MCL retractor, and most importantly, a lightweighted mallet, not our usual big mallets we use for a total knee replacement. So yeah, ideally speaking, this is the kind of X-rays which I always aim for. A good varus-aligned prosthesis where you have a good coverage of the implant positioning, and the femoral component is just aligned to the tibial component. The slope looks pretty good. The flexion of the femoral implant looks pretty good, and my correction of my HK is just right. Is what I intended for. All right, now looking at the long-term outcomes. So, I mean, whenever you look at the registries, especially the Australian registries, the number of unis performed is extremely less, and they report a lot of revision rate, almost 7% to 10% of revision rate by almost 10 years. And in fact, the Australian registry shows that the mobile bearing has a much more higher rate of revision at an early rate of revision. And the registry from NJR also shows the same, but comparatively lesser. They show almost like 7% of revision rate at 10 years. And even the American Joint Registry shows kind of a similar ones. Basically, all the Swedish registry, American Joint Registry, everyone shows a higher revision rate, especially when we compare to a total knee replacement. When you compare just with registries, almost twice or thrice is the number of revision rate when you compare it to a total knee replacement. So these registries are extremely good data. It helps us to, it's a big pool of data, which helps us to analyze multiple things. But then, how I look at registries is, it doesn't show you the actual outcome scores. So whenever we try to perform these kind of surgeries, there is, people, try to say that, oh, the registry data is not very convincing. It's like, there will be a high rate of revisions and all of that. But then when you look at the individual surgeon's data, it's completely opposite. These are the list of long-term outcome scores. One of the paper which I would like to mention is from the Rourke et al., where in 2005 they published almost 136 knees and average follow-up of 24 years, and they showed almost 84% survivorship at 20 years and 72% survivorship at 25 years. And very similar to a mobile bearing unis also, where this from 2009 paper, Pandit et al., 2,000 unis, and they showed almost 96% survivorship at 10 years. So the most important study which I would like to highlight here is the TopCat study, which got published in 2019. This is from the UK group, and their main agenda is to identify which is a better surgery, a total knee or a partial knee for anteromedial osteoarthritis. So it's a multicentric RCT. People were not restricted to perform any particular type of procedure. It can be a fixed bearing or a mobile bearing, and it happened across 27 sites in the UK. 68 surgeons participated, and they came up with a 5-year follow-up. And as per their results, it's a much more cost-effective in terms of the number of our patient visits. It takes A loss is much lesser for a partial knee replacement, and partial knee replacements, when compared to a total knee replacement, has substantially lesser revision rate is what they have come up with. So that also works well in my hand. So that's exactly why we also perform this kind of a procedure. And exactly how you look, I look at unis I'll be very happy to perform these procedures in a very young patient or even in an elderly age group. In a young patient, primarily because their demand is pretty on a higher side. And I'm sure these patients will be extremely happy when we perform a uni because it can meet those kind of demands. And the satisfaction rate when they climb stairs, there's no instability when they climb stairs, and when they perform some light active fitness lifestyle, they were much happier when we do a uni condyle knee replacement. Whereas in an elderly age group, it's much less morbid procedure and their recovery is much better. So that's how I would look at, when to perform these kind of unis. And just to summarize some, take home uni tricks, for uni is typically extremely important. Always rethink when we revise a tibia. The moment we do a tibia, we try to put a spacer block. We see if it's, if the minimum spacer blocks goes inside. If it's not going inside, don't immediately jump and, try to revise the cut. See if there is any osteophyte or something else which is blocking the way. And that's the way to, or fine tune it with just by, rasping the tibia for a millimeter or two. And then you can if still nothing works, then probably you can revise the tibial cut. And flexion extension balancing is pretty, very important. And component to component alignment is also very important so that you don't get any edge loading. And sizing of the, tibial component and the femoral component should be extremely meticulous and spend good time while you do the cementing. So also, just like the previous speaker said, it's a more like a resurfacing procedure. It's a gap balancing technique. Know your, alignment. We are not here to, correct the alignment. It's not a correct deformity corrective surgery. So our statistics, we have done close to almost like 400 to 500 joints, medial unis. And the best part is this is the surgery which has helped us to pave the way towards a daycare surgery. And the outcomes, the PROMs is phenomenally good. So that's the one which is actually pushing us and motivating us to perform more and more of these procedures. But however, we have also faced, few complications following this procedure like PJIs, malalignment and fractures. So the key part to give a repetitively good result is to, do, repetition. So occasionally when we do these kind of procedures, we may not be able to give a very good outcome in the initial phases. So, but initially you need to do at least a 12, surgery, be committed while you perform these surgeries, and minimum of 20 to 40% of your knee volume should, be of unis. So we also conduct an annual course on these unis, and this year 24 we are looking at a cadaver workshop also. So I'm sure interested people who wants to learn the nuances of the surgical techniques of unis, we are most welcome to join us. Thank you so much for this opportunity.
Thank you, Vetri. It was wonderful, exhaustive. So let's quickly go to the case discussions and then we'll take up questions. I'm sure there are a lot of questions. So I invite Dr. Bhupendra Patel. Dr. Bhupendra, please share your screen. Yeah.
Okay. So is it visible?
Yes, go ahead. We'll have quick case presentations and then we'll go to questions.
Yeah, okay. So I'm thanking Tamilnadu Orthopedic Association for the invite, and thank you, Karthik, for inviting me. So my philosophy basically is, am I audible?
Yes, perfect.
Okay. So my philosophy is actually I was trained in knee arthroscopy and knee replacement, basically total knee replacement. And so while sitting in the OPD, I was able to diagnose but not able to treat some subset of patients with the knee pain who were in 40s, 50s, were active in lifestyle, who have failed conservative and even arthroscopy surgeries. And even after doing post-STO patients, even they were not much happy. So, and ultimately, I came to know that this is a typical surgery which will solve my such patients. So I had to go to the Oxford course, and that miracle actually happened. This is my first uni which I did, which was Oxford Uni, and it was done in 2016. So, and since then, that miracle is happening again and again and each and every day in my life. So this is the case number 1, in which we can see the both knee x-rays, and the AP view is standing view, in which medial bone on bone appearance is there. And in lateral view, the patellofemoral joint looks good, and the anterior part of the tibia seems to be worn out. So when clinically we checked, the right knee was having ROM of 5 degree to 120 degree, and left knee was 0 to 120 degree. The varus was correctable on the both sides, and the patient was pointing at the medial side of the knee for pain. And on examination of hip, spine, and ankle, everything was normal. So this is the intra pictures, right and left both. They both have intact ACL, intact lateral cartilage, patellofemoral joint was good, and only medial compartment was involved. This is the post-op X-ray. It is a fixed bearing knee, and both AP and lateral view of the just immediate post-op. This is at 1 month post-op, clinical pictures of both knee of that patient, and she is able to do cross-leg sitting and very happy patient. So the another case is a 43-year-old lady who is housewife and was exhausted with conservative treatment. On examination, there was no FFD, full range of motion, and typically patient had localized medial side pain. And these are the X-rays which routinely we do actually. Single leg standing, valgus view, axial view, and lateral view. And that will be suffice in most of the cases. I don't do routinely go for MRI. If in doubt, and then I'll go for MRI, or any patient have any history of trauma, and I may suspect that ACL may have injured in the previous trauma, then only I will go for MRI. This is the post-op X-ray of the same patient. And this is at 4 weeks. Patient is having good range of motion, and the gait is very well balanced, pain-free, and very happy patient. The case number 3 is a female patient who has right knee pain, and X-ray, pre-op X-ray on the left side shows a medial bone-on-bone appearance. And this is the post-op X-ray at 1 year. Oxford Uni has been done here, which is a mobile bearing knee. And this is the clinical picture when she came for follow-up at 1 year. So post-op protocol for uni knee is almost same as TKR for us. On day 1, we keep patient on bed, and the exercises for preventing DVT and quadriceps exercises as patient is able to tolerate are started. From next day, patient starts walking with walker and weight bearing as tolerated. Patient may put full weight bearing on the same operated side, and knee bending, knee range of motion is also started. Most of the patients are able to walk unaided at 2 weeks, and further exercises at 2 weeks are started to achieve terminal range of motion in the form of terminal movements, prone bending, and everything. So we follow up our patients at 2 weeks, 4 weeks, 8 weeks, and 6 months, and then annually. So routine DVT prophylaxis is also as per the lower limb surgery we do. I have prepared one video of TUXplasty, which is a Tahoe unicondylar knee system. And should I start?
Yeah, please go ahead.
Okay. So this is a left side being operated. Sorry for the glare, but actually for my vision, it was necessary. This is a typical incision which I put. The speed is 2 times faster than normal. This is the amount of release just for approach. And then after exposure, we first see for ACL and lateral compartment and patellofemoral compartment. This is the assessment of patellofemoral compartment. Now I am going to get out the osteophytes from the femoral side. On the tibial side, I just remove the anteromedial osteophytes only, which hamper the surgery. This is the keeping the jig on the tibial anterior part, anteromedial part of tibia. This is the resection guide. Oh, shit. I routinely prefer for 5 to 7 degree slope. This is a resection of 2 mm at the defect. And I usually pin the 2 pins. The second pin would be just 5 mm inside the cortex. So if I want to do +2 cut, never raise your hand while doing recip. And this is the cutting the medial part of the tibial condyle. Horizontal cut. This is the tibial biscuit, which it is showing that anteromedial arthritis. Posterior cartilage is intact. This is the 8 mm spacer, which is minimum, and that is to be confirmed fast. This is sizing of the femur. So you can size this in the 2 method. This is the another method to size the how it will feel. This is positioning the 8 mm spacer and distal femoral cutting block, posterior condyle cutting block. So that would align the femur on depending on the tibial cut, and the intramedullary guidance will guide the femoral position so as to achieve valgus of the 5 degree in femoral component. It has 2 peg drills in the original femur, 2 pegs. So all 2 of them are drilled at this time. And then this is the cutting guide of the particular size which we selected. And usually we measure it in each and every case. It is usually 4 to 5 mm. Now I'll just checking that have I achieved the 14 mm gap or not. It is the 14 mm spacer. So flexion gap is 14, total implant. And this is checking of extension gap. So the flexion should be 14. The total implant thickness, posterior condyle of femur, implant, poly, minimum poly, and tibia comes to 14. And the same construct in extension is 12. So I'm checking what is my extension before my femoral rimming. So this is the 10 spacer, 10. So I need to rim 2 mm distal femur to achieve 12 mm total extension gap. This is a 2 mm depth. So that is created, 2 mm depth is created on the femur. And then now, depending on the size, the rimming will be done. This is a size specific rimmer. This completes the femoral preparation. The excess bone is removed. This is now I go ahead for tibia preparation, and this is a very precise instrument. It has posteriorly a spike which goes on posterior cortex, and then you pull and it will hang on the posterior cortex, and then you can size the tibia accordingly. This is the brush which we similarly use in Oxford knee. This is a trial component of tibia, and that keel goes into the preparation trough, and then the another lug hole is prepared on the same trial tibia. This is a trial femur, and this prosthesis has a ridge inside the femur, and that ridge is prepared with the recip at trial. This is a minimum 8 poly. This is complete extension and a good flexion. Now we will be going ahead with the implantation, cementing and implantation. This is a cementing femur. Every time I use the syringe to pressurize the cement. This is the original femur. This is a trial poly. Just to pressurize the components, and till the cement sets, I just keep it at 45 degree so as to have even pressure on the both components. This is the original poly, which is a vitamin E poly, and it fits very snugly, and a single short small tap is just needed to lock it. This is that, and the completion of surgery. So what are the tips to success? Is don't keep it too tight, except slightly loose feel, and don't overcorrect the deformity. Proper lateralization of tibial components to avoid the edge loading is most important things to see. Thank you.
Wonderful, wonderful demonstration, Dr. Bhupen.
Thank you.
Thanks for taking the pain to show us the video. It was good.
Yeah, actually, due to time constraint, I had to cut short many things.
You did very well. You made it look very simple.
And it was too fast, so I could not
Perfect.
explain each and everything in this much time.
We'll get back to you, Dr. Billy.
Yeah, I'll share my screen now. Karthik, can you see it now?
Yes, yes, we can see you.
Okay. So Karthik has given me about 5 to 7 minutes to present case. So I thought I'll just show you a few case scenarios that I've come across in my practice. Like Dr. Ateet had mentioned earlier, my selection criteria is very strict. And if you select the right patient, then your outcome also can be good. So I'm not going to go through this. So one of the most important things that I look at my patient is I ask the patient where the pain is. And if they say they run the fingers all around the knee, probably that is not suitable for a partial knee. And if they can kind of run around, show the fingers on the medial side or towards the anteromedial aspect, that's the ideal patient you want to operate on. So my first patient I'd like to show is a 52-year-old lady who works in a bank, gave 5-year history of arthritic type pain in both the knees. Walking distance was significantly reduced. She has noticed bowing of the knees. She had no comorbidities. And this, on examination, she had a bilateral varus knee, no flexion deformity, had a good range of movement, a varus which was fully correctable of less than 10 degrees. ACL was stable, and patellofemoral, there was some fine crepitus, but no irritability. So that's her X-ray. And as she had no comorbidities and she's a fit and healthy lady, I decided to do a bilateral single-stage partial knee replacement. And that's her immediate post-operative X-rays. And you can see it's a well-placed implant. There's a little bit of overhang on the left knee tibial component, about 1 millimeter or 2, but she didn't have any concerns with that. And that's her at her 8-year follow-up, and you can see that she's walking without any thrust and walking comfortably. So the second patient is a patient who's 57, who's a homemaker, who is on the overweight side with a BMI over 35. She had a typical arthritic type pain involving the right knee. Her walking distance was reduced to only about 50 meters. She had a varus knee, no flexion deformity, a reasonable range of movement, a varus of 10 degrees was fully correctable, a stable ACL, again with the patellofemoral crepitus, but no irritability. So that's her preoperative X-rays, which shows that she's got a predominantly medial anteromedial disease and some patellofemoral osteophytes, but nothing major. So she again underwent a partial knee replacement, medial compartment, and in most of my patients undergo an Oxford mobile bearing knee replacement. And that's her at her 8-year follow-up. She's got good range of movement. She's walking comfortably, and she's used to sitting cross-legged at home, which she's continuing to do so. The patient C, like Dr. Ateet had mentioned, age is not a criteria. This gentleman is 72 years when he presented to me. He's a farmer, and his only request was that he wants to return to agricultural fieldwork, which involves squatting down, going on uneven surfaces, and he works about 4 or 5 hours in that in a squatting position, and that's what he wanted. Again, on examination, he had a varus knee, no flexion deformity, range of movement 0 to 130. Varus of less than 5, which was fully correctable, ACL stable, and patellofemoral was normal. And those were his preoperative X-rays. I do varus valgus views to see if the lateral compartment is involved or not. That's his postoperative X-ray, and that's him when he came at his 6-week follow-up. And usually I call my patients back at 6 weeks, 6 months, 1 year on for the first 5 years. And he actually, following a 6-week follow-up, he just disappeared. And then as we were doing some research work, I got my fellow to call him and follow him up. And that's his 7-year follow-up X-rays, and he's doing extremely well. Now, this is the other indication for doing a partial knee replacement. This is a 59-year-old doctor with severe medial-sided pain of the left knee for a year. His walking distance was, however, not reduced, but he had this aching pain in the medial side. He had a varus knee on examination, no flexion deformity, range of movement 0 to 130, less than 5 degrees varus, fully correctable, ACL stable, patellofemoral within normal limits, and this is what his X-ray showed. And he's got a Sonk lesion. And his valgus varus shows that it's a correctable varus, no lateral disease. Again, he underwent a partial knee replacement. And this is his first post-operative day. So most of my patients, they are encouraged to walk without walking aids if possible. A cocktail of local anesthetic is given. Sometimes they get blocks. And this helps them gain the confidence of using their knee. And this is his 3-year follow-up X-ray. So these are the 4 cases that I thought I'll show today. And thank you.
Fantastic, sir. Excellent collection of cases and perfect execution of the surgery. I'm sure there'll be a lot of questions. So I'll open the floor for discussion. I have I'll start off with a few questions actually. Dr. Vetri was actually very open in showing all his cases, and he brought out a lot of excellent points as to how the surgery has to be done. And he spoke about Dr. Vetri, are you there?
Yeah, I'm there, but apparently I cannot switch on my video.
Okay. So you spoke about kinematically aligning the uni knee. Do you use some sort of navigation, or do you do it every time just freehand? Or what are your do you use any intraoperative imaging, or how do you go about this?
That's right. I mean, I wish I had some fancy gadgets with me, but then we don't have any of those. We just do it freehand. So as I explained, I would primarily it's all about the pre-op planning. I mean, if you look at kinematically aligning total knees, there are various techniques. Yes, robotics is the best way, but then you can do a caliper check technique, which is also pretty accurate. So very similarly is what we do here. I do it freehand.
Okay. Any of the other surgeons using robotic or intraop navigation, sir? Ateet, sir?
Yes, we are using the Cori robotic system for our unis also, mainly for TKRs and for unis also. But presently, as Dr. Bhupendra said, first we started with Oxford, then we shifted to fixed bearing to Depio, Smith and Nephew. But presently, the consensus tuxplasty, I think it's really perfect, and possibly you don't need a robot in doing a tuxplasty.
Okay. Fantastic. Sir, any other questions? I'll just get back again. Bala sir, Bhaskar sir.
Karthik?
Sir, yes sir. Thanan sir.
Can you hear me?
It's a question to
Yes sir.
Bala?
Thanavan sir, yes sir. Go ahead sir. Thanavan sir.
It's a question to Atil and everyone basically. Why did you all change from Oxford to a fixed bearing, a mobile bearing to fixed bearing? Is there any particular reason, or did you have any bad results?
Okay, I'll answer first, sir. We learned the uni on Oxford, and the mobile bearing technique was really good and very accurate. And there was one patient who there was a spin out. That was one concern which I had while changing to a fixed bearing. Second, the keel of the Oxford is pretty deep. So whenever we are revising from an Oxford, there is a lot of bone loss in tibia. While the keel in the fixed bearing knees, most all of them is a very small keel, or there are just lug holes. So these were the two reasons for me to shift to a fixed bearing uni.
The same question to Vetri?
Yeah, yes, sir. So yeah, I initially I learned unis by doing a fixed bearing that I did for a year or two, and then I converted to a mobile bearing unis. But majority of my cases are actually mobile bearing unis so far. But then now off late again, I've shifted back to fixed bearing unis. That's primarily because I feel mobile bearing unis are extremely good, and especially for the beginners, for us to understand balancing techniques, mobile bearing unis are extremely good. But then once you get the hang of it, I think fixed bearing unis gives a good modularity of confident positioning. Once you get the hang of it, I think we have a good modularity. And the time taking is extremely less compared to Oxford. And here the steps are literally 3 steps, the surgery is over. And moreover, I'm also looking at moving towards a lateral uni. So, off late we have started performing lateral unis. So if I start to do a more medial mobile fixed bearing unis, it's easy for me to start performing other compartments. So that's the reason why I've shifted.
Yeah, it's a question to Ateet. Can you hear me and see me?
Yes, sir.
Hello.
Yes, sir. Yes, sir.
Ateet,
yes,
don't
sir.
call me sir.
Yes.
I don't know whether you recognize me or not. I am just an immediate senior,
Yes.
BJ Medical College.
Okay.
Bhaskaran.
Yes. Oh, yes. Hey, hi. How are you?
Hi. Yeah, so you recognize me. Okay.
Yes,
Good.
yes,
Nice
of
to
course.
see you. Good presentation.
Yes.
Just I wanted to know that you have been doing uni very good. Because in 2007, when I was in UK, we used to scope and decide whether the patient needs a uni or a total knee.
Right.
Okay. So now we got an MRI scan, and in the backup, you can have both uni and the TKR, and then you decide on the table. How do you do that now?
Bhaskar bhai,
You do scope at all, or just
no. We decide primarily on the X-ray, as I told you. The standing AP views and the valgus stress views. Because see,
Okay.
you can get an MRI done in all the patients, but then you will become confused. There will be some contour loss on the lateral side, some fibrillation on the lateral facet of the patella. When you see these cases on table, you see that this is almost normal, a little bit of fibrillation, but valgus stress views will give you the exact picture of whether you can go ahead with the uni or not. And the lateral view, if you see clearly, and if you can see the posterior cartilage, then I think X-ray is the gold standard.
So posterior cartilage means you can have a normal space. You don't know whether it's normal for him.
No, it's not.
It varies from person to person whether you compare
Yes,
with the opposite side.
Yes, when you see the lateral X-ray, then you will be able to see that the femoral condyle is placed within the center of the tibial condyle, and it is not going beyond that. It is not subluxating. Yeah.
Okay. Sure. Good.
Sir, Bala sir wanted to ask a question.
Hi. Question. Someone has shown uni for song.
Billy sir.
Yeah, I did show. Yeah.
Exactly. Yeah. Song basically is osteonecrosis. When you prepare the femoral condyle. So if there is if the blood supply is not good or if the bone is soft, are you happy to do the uni?
No, so you don't do it when there's a lot of edema. So the one that I showed is where the edema had resolved. I didn't show the MRI scans, and also it had collapsed, and the disease is basically stopped. But he had this varus deformity and he had pain. So that's where I chose to do a partial knee for him. Only the thing is, when you do the technical tip is that when you do the milling for a song, you don't want to over mill it. So when we use, we used to use a zero. The Oxford system. So when you have the zero spigot, you just mill it so that you are just about able to see it within the window, not when it touches. So that's very something that's important. Yeah.
Well, you look for a complete intact ACL. When you do sometimes, when you cut the tibia, you might damage the ACL. There is risk. Then will you change that into TKR, or how far you accept that ACL?
Often when the ACL, it runs across into the medial tibial spine. So like Vetri had mentioned, I don't really worry too much if I just go into the footprint of the ACL. It's a fairly broad footprint. It doesn't just avulse. But the most important thing is when you do go into the medial tibial eminence, your horizontal resection, don't undercut too much. So that is a bit of a risk factor. So as long as that's okay, I don't worry about it.
Sure. Okay.
Dr. Ateet and Vetri, what would you do in a recurvatum knee? Is it can you do the surgery, and what would you do in an FFD? Bhupen, all of you can answer. Ateet, sir.
Okay, I'll answer first. Recurvatum knees, I feel that uni is a contraindication. It's very difficult for you to balance a uni in a recurvatum knee because the extension gap opens up significantly. But still, if it is about 5 degrees of hyperextension, then possibly you will be able to manage it. For that, you cannot do any of these Johnson & Johnson or Smith & Nephew, because they have a fixed extension cut out 4.5 millimeters or 6.5 millimeters. You have to have either a consensus tuxplasty or maybe a mobile bearing if you are strong enough. So possibly recurvatum, please don't do it. Otherwise, there are chances that you may end up doing a TKR in the same patient in the same sitting. For a fixed deformity, yes, you have to see how much is the fixed deformity. Some fixed deformity can be corrected while doing a uni, and what they say in the Oxford that if some amount of FFD remains at the end of your surgery, it will get corrected over a period of time.
Yeah, and another thing is, normally, before this cross-linked polyethylene, you want to have some certain poly thickness.
Yes.
Okay. So now you say 6 millimeter is the minimum available.
Yes.
So which one you're looking for? Optimum poly, whether you're happy with the 6 millimeter, or okay, I want to go another size, to give adequate poly thickness so it can last longer, something like that, No,
not like that. In a PFC Sigma 8, we usually go for 10. The lowest one which is available, we try to go for that only, because the higher you want to go or aim for, you will have to increase your tibial cut, which is not good.
Sure.
Yes.
Okay.
Yes.
So you aim for only minimal poly.
Minimal.
Okay. You're happy with that. Okay.
Sure.
Thank you.
Yeah, for recurvatum, same as Ateet sir said, I haven't attempted it. and I will not attempt it, never ever. And in the flexion deformity cases, actually each and every case I do uni, I examine them pre-op and after anesthesia. Each and every case I examine myself, and I get to know that whether the FFD is corrected, how much degree is corrected. On X-rays, posterior to posterior condyle of femur, how big is the osteophyte? That would tenting the posterior capsule. And while doing this consensus, we actually are very easily able to see the posterior part. So we can remove the osteophyte very well. And while resecting the distal femur, rimming the distal femur, this rimming system is very easy to perform, 1 millimeter, 1 by 1. While cutting it with saw is quite difficult. So the rimming system is very easy to get it corrected.
Fantastic. Anything more to add? Anybody?
If I can, I mean, for FFD, when we talk about FFD, so I also like every other surgeon, we definitely, after anesthesia, we look at, how much is the FFD. But most of the time, it's also the reason of unwell osteophyte, which will be the reason for the, which is like the door stopper effect. The moment we remove that, also you get a good correction of FFD. So that's one thing which I'll keep it in mind. If there is an unwell osteophyte, then probably I would say and if it's less than 10 degrees, probably I would still go ahead and perform it with less than 10 degrees. Yeah, hyperextension, I would just agree with all the other speakers. I don't attempt to do a hyperextension beyond 5 degrees, but less than 5 degrees, I will always attempt it. And if there is a big gap mismatch, then probably I might convert to TKR on table.
Any other questions, or shall we?
Sir, good afternoon, sir.
Yes.
Sir, I'm Dr. Hemnath, sir. Sir, I would like to know what would be the ideal position to take a tibial cut, sir. Ideal position of the knee. What degree of flexion would be the ideal position to take the tibial cut as such in UKR, sir? Because in TKR, we are removing the soft tissue structures. We are keeping it at maximum flexion, heel to buttock position. In UKR, what would be the ideal position to keep the knee joint so that we don't hit the femoral condyles?
So,
it's probably the 90 degree.
Sorry. Yeah. Please go ahead, Mr.
Yeah. So mostly it is in the 90 degree position. Knee is flexed 90 degree, and
Yes.
there is a trick. So as where the plane would lie, I just pass a 5 millimeter curved osteotome just medial to the ACL.
Yes, sir.
Yeah, and just below the PCL. So you just pass an osteotome, there is a potential gap there,
Yes,
and
sir.
there you go.
Yes. Thank you.
Sorry, where do you pass the osteotome?
Just medial to the ACL footprint.
You just to
On the
protect
tibia,
your,
and I will just slide.
just to protect your ACL.
No. Just to assess the flexion plane.
Okay. So, Karthik, one of the things you do is when you use your sagittal reciprocating saw, similar to what Bhupen said, to use an osteotome. So I put that across there, and then you flex and extend the knee a few degrees. And that will give you a very clear idea where the flexion extension axis is. And you just run your saw down. So that's all you need to do. And then depending on the soft tissue, how much of fat you got, the retropatellar fat pad, you can put it in various degrees of flexion, but usually it's around the 80-90 degrees of flexion.
Ateet, sir, anything?
Yes.
Do you agree? It's at 90, almost.
It's 90 degrees. It's 90 degrees. Yes.
Karthi,
Sir.
question to everyone. The Oxford advises a leg holder for doing the uni, but anybody using leg holder or just normal table?
Yeah, no, I use a normal table. I started using the Oxford when they were in their phase 2 instrumentation, and that it was a bit of a struggle. And also the implants, the inserts that they had at that time, it was not easy to insert it. So you used to have a lot of distraction. We were not sure how much to balance it. But with the current instrumentation, the microplasty instrumentation, you don't need. You just need a standard TKR supine is enough. You just need an assistant to just give a lift of at the femur, and then you can do it. So you don't need a leg holder.
Okay, okay.
Fantastic. Yeah, Bhupen.
While doing Oxford, I always use a hanging leg position, and fixed bearing I do in TCAP position.
Okay.
Same goes with me as well. Oxford, I always do it with a leg holder, leg hanging position, but fixed bearing, TCAP is the best. Yeah, the usual position is pretty good.
So just one last question. Vetri had brought out a point about distalizing the joint line. Ateet sir, Billy sir, and Bhupen, do you worry too much about distalizing the joint line? Do you want to have it parallel to the lateral side all the time, or how do you go about that actually?
No, I was actually talking about we should not do a distalizing of the joint line. We shouldn't do.
That's what I'm saying. How do you avoid it? That was the question I was asking.
By resecting adequate amount of the femoral. So that's the only method.
So by if you resect more the femur, will it not anti-rise your?
No. I'm not saying like more. I'm saying adequate amount of femur has to be resected, and same thing. It's all about the resection height. You take too much of tibia resection, then probably you need to go distalize. If you have already taken too much on the tibia. So you have to if you've just taken the adequate amount of tibia, then probably you need to or if you have resected less than the tibia, then normally what you do is you resect excess from the femur. So it's just have to be extremely perfect. That's what unis, you are hardly playing with a millimeter or two. So yeah, I mean that's what, if it's too much asymmetric, then it's a big problem. But a millimeter or two, nothing much actually.
Excellent.
I think the whole, like you said, the whole important thing in when you do a partial is your tibia is the crux. Your tibial resection and has to be as perfect as possible, and then it just follows through. Whether you're doing the Oxford or whether you're doing the tuxplasty. I don't have any experience with the tuxplasty, but from what I understand when I went through it, it's a very good system, and it just guides you through.
Anything to add, sir? Ateet sir, Bhupen, anything to add? Fantastic. I think we had very good session, big eye opener for everyone. And I invite our treasurer, Dr. Tenavan, to deliver the vote of thanks.
Thanks, Karthik. Thank you so much. I thank all the faculties, especially Sharma, Vetri, Bhupin, and Billy, to give an excellent lecture and give an input onto the Oxford knee replacement or the unicompartmental knee replacement, any side. When I came back from UK in 2008, Oxford knee replacement was sort of unknown to most of the places. And now I am feeling very happy to see that most of the people are doing unicompartmental knee replacement. And thank you so much for arranging a wonderful Ortho TV conference, Karthik, for you also. And all the participants who took the time in the night and enjoyed the talk. Thank you so much.
Thank you.
Thank you very much.
Thank you so much. We enjoyed thoroughly. Yeah, thank you.
Bye-bye.
Analysts also, thank you, sir.
Yeah, bye.
Thank you very much.
Thank you, Karthik.
Thank you.